The following podcast is part of a certified educational activity titled Targeting a New Approach in COPD, Understanding the Potential Role of Biologic Therapy in Patients with Evidence of Type 2 Inflammation. Access the entire activity and complete the post-test at peerview.com/MKD860. Downloadable slides and practice aids are also available.
Welcome, everybody. Today, we're going to be talking about targeting a new approach in COPD. First of all, my name is Dr. Jamie Rutland. I'm a pulmonary critical care physician in Southern California. We're going to be joined by a good friend of mine, Dr. Stephanie Christensen. I want to say hello.
Hi. Hi, Jamie. Good to see
Hey,
you.
good to see you too. So we're going to talk about understanding the role of biologic therapy in patients with evidence of type 2 inflammation that have COPD. So what are the goals? Well, we're going to talk about type 2 inflammation and COPD pathophysiology. I think it's important for us to understand the inflammation that has been well characterized in a certain type of inflammatory process in this specific respiratory disease. We're going to equip you with strategies for identifying patients who are potential candidates for targeted therapies, right? And we're going to ensure their comfort with the possible use of these biologic agents, or what I like to call them cellular communication inhibitors. We're also going to provide some guidance on how to integrate these findings from clinical trials in the treatment of patients with COPD and type 2 inflammation. And Stephanie's going to go through future clinical trials or clinical trials that are ongoing that may actually affect the way that we practice in the future as well. So we're going to start with understanding the role of type 2 inflammation in COPD pathophysiology, but more importantly, we're going to talk about type 2 inflammation. We have to understand that the World Health Organization estimates that by 2060, more than 5.5 million deaths per year are going to be attributed to COPD and the related coexisting respiratory conditions. Exacerbations of COPD, it doesn't matter what the severity is, they lead to a poorer quality of life. They lead to increased hospitalizations, which we classify as a severe exacerbation, and an increased risk of death. So it doesn't matter, even with all the effective management strategies we have today, the burden still remains high, and there's a significant amount of inflammation as a result of COPD that leads to significant morbidity and mortality. When you look at exacerbations, this is the single greatest risk factor for death and for mortality. You can see that individuals that have a severe exacerbation, which we defined here in this study as individuals who presented to the hospital with an exacerbation of COPD, these are the individuals who are more likely to die when compared to other individuals who just have moderate exacerbations. And a moderate exacerbation is an exacerbation of COPD that can take place at home. When we talk about COPD, and a lot of times when we just say this word, we don't actually define it. I know everybody is a healthcare practitioner and a healthcare provider, but again, COPD really encompasses two different illnesses. One is chronic bronchitis, which is inflammation of the pipes that are carrying air to the lung. That inflammation leads to a lot of mucus production. And then another one is actually emphysema, which is really just dead lung. We all know that the lung is a bunch of pipes that lead to a bunch of balloons all stacked on top of one another. And when those balloons pop, that's emphysema. That's dead lung. When you look at this inflammation, we all know that when you look at the lining of the respiratory tract, you got a bunch of different airway epithelial cells that are right next to each other. And these airway epithelial cells, they're not just one type of cell. There's a club cell. There's neuroendocrine epithelial cells. There's all kinds of airway epithelial cells that characterize themselves by different receptors located on their membrane. But if you can think about every single breath that you take, you are snatching the environment that surrounds you and you're introducing it into the inside of your body. You're introducing it to these airway epithelial cells. Now, these cells, if you have that genetic predisposition to do so, or if you're exposed to air pollution or smoke, these cells are going to respond. They're going to secrete molecules that we call alarmins, or damage-associated molecular patterns, interleukin-33, TSLP. These alarmins are then going to bind to their respective receptors on other cells. They're going to bind to the dendritic cell. They're going to bind to innate lymphoid cells, type 2s. And then these cells are then going to ensue an activation of an inflammatory response. Once these cells are activated, they may actually turn naive T cells into what's called Th2 cells, and they may activate the innate lymphoid cell type 2s. That's why we call this type 2 inflammation, right? So when these cells are activated, they're going to secrete their own respective cytokines. Interleukins 4, 5, 9, and 13 are the characteristic type 2 cytokines that we describe in type 2 inflammation. These cytokines are in turn going to act on their receptors, either activating an inflammatory response or leading to physical manifestations of illness. So let's look at interleukin 13, for instance. Interleukin 13 is actually going to stimulate the goblet cell to make more mucus. More specifically, it's going to make more MUC5A or MUC5AC. These are mucus that like to really tether to that cell, and they're really, really dense, thick mucus. Interleukin 4 is going to lead to the production of IgE, along with interleukin 13's receptor. Interleukin 4's receptor can actually activate what's called macrophage polarization. So you switch from a macrophage that is secreting inflammatory type of mediators to a macrophage that's going to secrete more recruiting types of cells that lay down collagen, the fibroblasts and myofibroblasts. Needless to say, all of this leads to destruction of that lung. It can lead to inflammation of the bronchiole and destruction of those alveoli, which can be a real problem when we think about these individuals with COPD. When you look specifically at type 2 inflammation in individuals that have chronic obstructive pulmonary disease, this can be present in up to 40% of patients. Those 20 to 40% of patients with COPD may have type 2 inflammation, and that type 2 inflammation is associated with exacerbations. When you look at type 2 molecules, right? So if you look at CLCA1, which is a molecule that actually enhances mucus secretion, or if you look at CCL26, which is also called eotaxins 3, one of the problems that I have with cytokines is that they all have like 15 different names. So I think it's important for us to understand what these names represent. So like if you look at CCL26, which is also eotaxin 3, what it does is it actually leads to the displayment of receptors on tissue that recruits eosinophils into the airway, right? So it's responsible for that recruitment. And you can see that in a lot of these inflammatory mediator molecules that they are associated with eosinophilia, right? So these are type 2 inflammatory type of molecules that are associated with eosinophilia, right? Interleukin 13, eotaxins 3, CLCA1. And when we look specifically at interleukin 4, interleukin 13, and interleukin 5, you can see the specific instructions that it's giving the body, right? So I mentioned earlier about interleukin 13 stimulating that goblet cell to make more mucus. You can see excess mucus production here. And then you can see collagen deposition, right? So interleukin 4's receptor and interleukin 13's receptor tend to respond together. So they dimerize together, which leads to the downstream of events when I talked about that macrophage polarization. Interleukin 4 also stimulates the plasma cell to make more IgE and IgG1. IgE is going to bind to that mast cell, it's going to bind to that basophil, it's going to bind to that eosinophil, causing release of those inflammatory mediators. Remember when we were all in medical school, we were looking under the microscope. When you look under the microscope, you see these cells with lots of granules in the cytoplasm. That's probably the mast cell or the eosinophil or the basophil. So when IgE binds to those cells on its FC receptor, it's going to release the more inflammatory mediators. And within those granules is periostin, TARC, eotaxins 1, 2, and 3. And it leads to a lot of epithelial barrier dysfunction. And so when you have this epithelial barrier dysfunction, you get a lot of what I like to call holes in that white picket fence that protects your airway, right? And so when you have these little holes in these white picket fence, you get inflammatory mediators and other antigens from outside penetrating deep within the tissues, exacerbating this inflammation. So when you look specifically at these cytokines, and you can see the nice picture here, you can see that these airway epithelial cells are going to secrete these alarmins. These alarmins are going to activate other inflammatory mediators, other inflammatory cells, and then you're definitely going to get the pathophysiology of the disease that we see in our patients. And so when our patients come in, they're going to wheeze, they're going to cough, they're going to produce mucus, they're going to be short of breath, all as a result of the cytokine biology, which we can describe pretty well in type 2 inflammation. And I think is very important for us to not only be able to recognize when our patients present in this manner, but also be able to go to the lab, right, and recognize what cell parameters or what lab values are associated with type 2 inflammation. So now what we're going to do is we talked about that pathophysiology. We talked about the cell to cell communication that takes place, which is important. But now we have to apply that cell to cell communication with our clinical practice. How are we going to actually identify these patients with COPD who can be candidates for targeted treatment? How are we going to use biomarkers to our advantage? So, when you look at the current pharmacologic approach, it's very what I like to call bomb like, right? We try to drop a bomb on everything and just kind of be okay, let's just reduce inflammation overall. So there's a proportion of patients with moderate to severe airflow limitation who continue to have exacerbations, and they're on their triple therapies, right? So there's an underlying inflammatory process that's taking place. Some of these patients with COPD and high eosinophil counts are more likely to have exacerbations. And we know that the current maintenance therapies don't specifically target type 2 inflammatory mediators. That's why it's very important for us to be precise with our therapeutic strategy, right? I really, really like to be precise. That's why I love cytokine biology. Other than the fact that they name all the cytokines 15 different things, I do love cytokine biology because it takes into account not only the endotype, but also the phenotype. So the endotype, which we define as biological information, which is detected using biomarkers, and the phenotype is those clinical features. So an example would be you have a patient that presents with a lot of mucus production, right? So what molecule is going to represent that interleukin 13 upregulation, right? What's going to represent that increase in interleukin 13 levels? Well, there's a molecule that's called pheno, which is heavily associated with rising interleukin 13 levels. So the higher the pheno, the higher the interleukin 13, you're going to see more mucus anyways. So we based our treatment decisions on that. We're using not only the phenotype of these patients, but we're also combining that endotype to truly understand what's going on from a cell to cell communication standpoint and improve our practice and improve our therapeutic strategy in our patients. So we want to look at blood eosinophil counts, right, which is predictive of an enhanced response to corticosteroids and targeted therapies. We also want to look at pheno. Here's the thing about pheno is an exhalational product of nitric oxide, which you can measure when you breathe out. Under the influence of interleukin 13, we actually induce more nitric oxide synthase. There's 3 types of nitric oxide synthases within our cells. And so this is inducible nitric oxide synthase. And what it does is as it converts citrulline to arginine, you actually release nitric oxide, and you can measure this. We also look at periostin. Now, this isn't something that we measure on a daily basis in our institutions and our labs. I think we're getting to that point, but we're not quite there yet. But again, periostin is elevated in current and former smokers with COPD. We have other studies and future studies that are going to understand this a lot better, but it is an important cytokine. IgE is associated with occurrence of exacerbations in men with COPD and the risk of lung function decline. But again, high IgE, again, that IgE is going to bind to that mast cell, to that basophil, to that eosinophil, activating the inflammatory response. So it is a type 2 biomarker. So it's something that's important for us and something that's easy for us to measure. Here's an interesting paper that was published by Singh and colleagues within the last couple of years. This actually looked at eosinophil count and other parameters, and the lower the eosinophil count, the more likely you're going to have a Haemophilus influenzae infection, and you're going to have an increase in your microbiome, your proteobacteria, and also have an increase of bacterial infections, which I thought was actually quite interesting. But as you increase that eosinophil count, we saw more tissue eosinophils, we saw more T2 mediators, and we actually saw a better response to inhaled corticosteroids. So again, we're still understanding this inflammatory cascade and what it means to our patients, specifically with COPD. But I think being able to explain the science and being able to articulate what this paper is telling us allows us to further recognize what our patients are going through and how to identify these specific patients. There's definitely a correlation between pheno levels and blood eosinophil count. So the higher that pheno, the higher that blood eosinophil count. And you can see that here very nicely. And you can also see the effect on clinical outcomes after a certain follow-up period here. So when you look at pheno and levels in COPD, you can see Hospitalization may go up a little bit. You can see mortality may or may not go up a little bit. But again, I think it's important to think about FeNO as it represents interleukin 13 level as a type 2 cytokine. That's how I think about it. So when I'm measuring FeNO, and I consider anything above about 20 parts per billion to be significant when it comes to type 2 inflammation, that's how I use it. I don't say, hey, Billy, your FeNO level is 75. You're more likely to die in 12 months. I don't say it like that. I just say, hey, your FeNO level is 75. We have an opportunity here to intervene on your disease state. And I think that's where the importance comes from. And that's where the interpretation from the data is important as it applies to our patients. So we want to identify these patients at risk for exacerbations. We want to look at the lung function, right? We all know to measure lung function. We all know to look at FEV1. We want to look at the symptom burden. Now, whether you're using MMRC or your COPD assessment test, it doesn't matter. We all kind of do this just naturally when we're talking to our patients. It's important for us to write these things down from a research standpoint. But again, it's really important for us just to ask those questions. And then you want to look for functional abnormalities. Does this patient have a dilated bronchiole in comparison to that pulmonary artery, which is bronchiectasis? Does this patient have the ability to be able to clear mucus secretions? I've got a mother-in-law right now that's not doing well in terms of her COPD. She produces a lot of mucus and has a lot of exacerbations, and she has demonstrated type 2 inflammation. But we also know that some of these risk factors actually lead to a reduction in the microbiome diversity. You can also have immunoglobulin deficiency. Now, I think this is important. As a pulmonologist who loves immunology, I really apply this to my clinical practice, and I check a lot of IgG levels in my respiratory patients because I do want to know if there's an immunoglobulin or an IgG deficiency associated with my patient in a respiratory disease, because there are therapeutic targets for that, right? There are therapies that can help these patients. And then you want to look at under-recognized or unrecognized etiologies. So does this patient have a central airway collapse? Do we need to get a CT scan? Does this patient have reflux disease? Does this patient have vocal cord dysfunction? And then obviously we're going to look at that blood eosinophil count and that sputum eosinophil count, which I think is important as well. So I want to bring Stephanie in here just because she's an expert. She does all the research. I just read her papers and interpret it. What do you think about this biomarker assessment influencing our clinical decisions?
Yeah, I mean, I think there's really good data for eosinophils, and I use them kind of as I think also the gold experts kind of assimilated some of this data into their recommendations, or at least into their report as well. That I really use eosinophils to guide my inhaled corticosteroid use. I will say I oftentimes use inhaled corticosteroids in a lot of my patients who are exacerbation prone. But certainly if I see you as less, as one of those patients who has uh, EOs less than 100, that group that maybe is more prone to dysbiosis, meaning elevation in pathogenic bacteria in their airways, that you might be a person who maybe is frailer or maybe has more pneumonia. I may not give you inhaled corticosteroids if you're an exacerbator. So I think I will use it certainly in those settings. I think we're going to talk about the biologics here coming up, and we have some exciting new drugs coming. Well, one that's FDA approved, but then others that are still being studied. So I think there's going to be a lot with biomarkers kind of coming up where it may be even more important. But I'm hopeful that we can start getting a lot. I think I'm seeing a lot of our pulmonologists using eosinophils, and I'm hopeful we can get more of our primary care physicians using eosinophils, because I do think it's really useful, because some of these drugs are very helpful for our patients. What about you? It sounds like you really like using them.
I, I mean, yeah, I use eosinophils and other markers. It's super interesting when you read the medical literature on low blood eosinophil count, because as you just stated very well, I'm starting to take that into my clinical applicability, I guess. Like understanding that, oh, wait, not only do they have low eosinophils, but that is also a risk factor for certain types of pneumonias. I need to be a little bit more conservative when I'm managing these patients, right? Maybe eliminating that inhaled corticosteroid, or monitoring them during those winter months, or asking them questions like, Do you have grandchildren? Are you around them a lot? Do you watch them a lot? Because that increases the risk for pathogenic, bacteria, viruses, things like that. So it's super interesting to bring that into the fray. Um, One of the questions I have for you is there a lab parameter that's studied in research now routinely that you see moving into clinical practice soon as it pertains to type 2 inflammation?
Yeah, I mean, I think it's a little tough. I think maybe we will see pheno, but that's a tough one because it's not measured everywhere. Like we don't have it in our lab I'm at University of California, San Francisco, and we don't really measure it. So I think that one's still kind of up in the air. And we need a lot more study on it. Not to mention that it's for for COPD, it's a little we still don't really understand, how it works, in the setting of smoking, because it's definitely decreased with smoking, but we don't know if it's still kind of works in maybe a different, range, that it's still, like, higher in type 2 high, but maybe the range of type 2 highness is just kind of shifted lower. So I think that one is certainly possible. We're already using it in asthma, particularly in Europe. They use it a lot. Um, I think IgE, we use it for allergy a lot, of course. I think in COPD, it's a little more complex. It may require that you have exposures or have some other type 2 high um markers, but I think it's kind of interesting. And then I think as we kind of move forward, trying to think about other non-invasive approaches, and I think we're studying a lot of those in our big cohort studies, using kind of other biomarkers or big data omics markers and trying to understand what can we measure non-invasively that might be a better biomarker. Because I think blood eos are not the end all be all, certainly not in COPD, where in asthma, we've got a wider range of eosinophils that look like they're actually useful. Whereas in COPD, you really have to have these really high levels for us to really and we'll show some of that data to look like you're responsive to some of our biologics and understanding kind of what's going on. Do you really have type 2 inflammation at some of these kind of more modest ranges? I think we may need a better biomarker than blood eosinophils, because I think we have a lot of patients we'd like to help that maybe aren't going to meet our criteria for some of the drugs that we're kind of looking at for treating uh, exacerbations that are resistant to our inhaler therapy.
I think it's up to you now, Seth.
Well, hey, we'll see. All right. I think we're going to now discuss the latest clinical trial data on potential use of biologic agents for COPD treatment. So, we're going to talk about kind of the studies that have been done, and in particular the positive studies, as well as kind of what's coming down the pipeline. And I think Jamie really set up nicely all the biology so that we can kind of think through um, the the results from these clinical trials with maybe a little bit more in mind about what is that biology that's underlying this, and maybe how is it um different than how we're thinking about an asthma patient, or how is it how might we eventually think about using these drugs, let's say if um in our best case scenario, several of them get approved. All right. So I'm Stephanie Christensen. I'm an associate professor of medicine at University of California, San Francisco. And as we said, I actually am a biomarker scientist. I'm a computational biologist and also run clinical studies. Um, just to kind of set the stage, let's first kind of talk through, well, what are we currently doing? However, how we treat you is really based on your treatable traits. So, meaning your exacerbations and your symptoms. As far as initial treatment recommendations for group B, that symptomatic group, and for group E, we basically recommend the same thing, and that is a LABA plus a LAMA. So not just a single inhaler alone, but a long-acting beta-agonist and a long-acting antimuscarinic together as kind of your first line therapy, because we've shown in studies that combining them really actually improves both symptoms and exacerbations better. However, if you have blood eosinophils greater than or equal to 300, we actually suggest as kind of your first line therapy that you're actually on triple therapy, meaning not only those two bronchodilators, but also an inhaled corticosteroid. And then what do we do next? Well, a lot of our patients still have symptoms, right? And so this is really the GOLD reports follow-up pharmacologic treatment recommendations. And there have been a couple of options already. Roflumilast, which is for lung function less than 50% and chronic bronchitis. Azithromycin for former smokers. Now FDA approved as ensifentrine, which is not on the GOLD report yet, but it is another PDE3, PDE4 inhibitor that's inhaled and could potentially be used in chronic bronchitis. They have not put this in the GOLD recommendations yet, but it is now FDA approved. And then the other drug that is now FDA approved for continued uncontrolled COPD, as per the FDA reports, is dupilumab. So meaning for type 2 for COPD, who exacerbation prone on triple therapy already, so continue to exacerbate, that we could consider adding this drug dupilumab. And let's show you the data behind using biologics in COPD. Now we're going to talk about the biologics, and we're going to start by talking about studies on two drugs targeting the IL-5 pathway. So mepolizumab, which is an anti-IL-5, and benralizumab, which is an anti-IL-5 receptor blocker. And so mepolizumab, their first two studies kind of showed mixed results. So what they looked at was patients with COPD, history of exacerbations, and greater than or equal to blood eosinophils of 150 at screening, and usually they had to have 300 or more, depending on the study, prior to that. And what they found was some mixed results. So metrics showed that there was no difference in exacerbations, and Metrio showed that there was an 18% reduction. So not as big a difference as we may see in some of our other studies, but they did see that in these patients with greater than 150 blood EOs at screening, that they did see a slight improvement in only one of their two studies. Now, their post hoc analyses, where they looked at where they kind of did cuts by their blood eosinophil counts, and we'll see this over and over again. And we saw this certainly for our inhaled corticosteroid studies as well, that it looks like as you increase your blood eosinophil count at that screening visit, that your response to the drug goes up. And so here again, these are the Galathea and Terra Nova studies for benralizumab. We'll see kind of that they did a responder population responder analysis, and found that in patients with history of several exacerbations, higher eosinophil counts, so with increasing eosinophil counts and with exacerbations over the course of their over the course of the study, that those people seem to be better responders. So even though they're not really seeing that, again, that there's any exacerbation reduction across the Galathea or Terra Nova studies with benralizumab, they do see that there may be a responder population, again, with higher eosinophils. So we're going to talk about dupilumab next, where we did see positive results. And as a disclosure, I am an author on this study, but this is the phase. So we're going to talk about the phase 3 Boreas and Notice trials that were published in 2023 and in 2024. And so both of these are double-blinded, randomized, placebo-controlled trials looking at eosinophil counts of greater than or equal to 300 in both symptomatic patients, so patients with a history of chronic bronchitis, and increased risk of exacerbation, so 2 in the past year or 1 that was severe, and that they are receiving add-on therapy in addition to their standard of care, which was almost always, I think 98% of patients, was triple therapy, so an inhaled corticosteroid plus dual bronchodilators. Okay. And so then they randomized 935 patients to dupilumab for placebo or versus placebo for 52 weeks, and then they followed them over an additional uh, 12 weeks, looking at lung function and other parameters. And this is so actually both studies, both Boreas and Noticed, showed a reduction in exacerbations. And in the pooled analysis that was presented at ERS this year, the combined analysis of Boreas and Noticed showed that overall there's about a 31% reduction in exacerbations in patients receiving dupilumab plus triple therapy versus triple therapy alone. So a pretty decent exacerbation reduction. Um, they also saw that kind of across the board, that there was an improvement in lung function. And what's kind of nice to see here is that, or interesting, at least, because interesting to think about the biology here again, is that we see that the lung function really improves by week 2. So it's something that's beyond just like the epithelium is completely changing, because that can actually take a while for the epithelium to remodel, but potentially suggesting maybe there's even a smooth muscle interaction here where it's leading to improvements in bronchodilation at a very early time point, or maybe some improvements in mucus plugging, although that actually takes a little time to improve as well. So still kind of jury's out on exactly what it's doing to improve this lung function so early. But what's really nice to see is that we see that these lines do not cross at all, meaning that that dupilumab is consistently showing an improvement in lung function over time. In Boreas but not Noticed, they did see an improvement in quality of life, or in symptoms overall. And this was another study from ERS showing that in non-exacerbators, results from Boreas is really showing that quality of life here is improved with dupilumab. So kind of really suggesting that, hey, even the patients who maybe didn't have an improvement like who never exacerbated over the course of their over the course of the study, did seem to have an improvement in quality of life as well. Importantly, and I think this is, really being shown fortunately, across studies in both asthma and COPD and in other indications for a lot of these biologics, is they appear to be really safe, meaning that we really don't see any difference between either any adverse events or severe adverse events between the placebo group and the group getting dupilumab. We're gonna show a video clip starring our own Jamie Rutland here on shared decision making. So making decisions about using some of these drugs, and giving facts about treatments and recommendations to the patients, and also kind of taking in their values and preferences, certainly in understanding whether some of these drugs are actually right for them. So let's take a look now at Jane, a patient who's had COPD for several years, and despite being on triple therapy, still experiences persistent symptoms and exacerbations 2 to 3 times a year. So for me, I'm like, okay, that's a very at-risk patient. These exacerbations could be very detrimental. And in this clip, we'll observe the shared decision-making process as Jane's eligibility for initiating biologic therapy to treat her COPD is discussed.
Hey, Jane, good morning. How are you?
I'm fine, thank you. I'm about the same, really. I'm just really frustrated. This shortness of breath makes everything more difficult.
I get it, and I wish we could have this visit in person, but unfortunately, we got to do this telewise. But I do get to give you some vital information today. So, do you want to hear about your lab work?
Certainly.
So, we checked your labs, and under normal circumstances, whenever you're evaluating a patient with COPD, you have to think about how that airway can interact with the environment, because every breath you take, your airway is interacting with the environment. And we look for signs of inflammation in your serum. And so we looked for signs of what we call type 2 inflammation. And so When we evaluate your blood work, I look at your complete blood count with a differential, and I look for certain types of white blood cells. Now, one of the white blood cells in your bloodstream is called the eosinophil, and your eosinophil was high, and that's associated with type 2 inflammation.
Well, what's an eosinophil?
Such a great question. In our bodies, we have an immune system, and the immune system derives from our bone marrow, which is deep within our bone. And there's different types of white blood cells that get produced, and they all do different things. Now, what we know about the eosinophil is it's heavily associated with allergy. And because of that, it can cause a lot of inflammation, especially in the airway. And that inflammation can lead to the symptoms of wheezing, mucus production, coughing, all of these things that you feel as a COPD exacerbation, I know as an inflammatory problem secondary to the eosinophil.
Okay.
So here's the way that we move forward. When you think about somebody that has a high eosinophil count and they have your airway disease, this gives us options. So not only are you on inhaler therapies that calm down the inflammatory response, but now that we know your eosinophil is high, we can use a different medicine that we call biologics.
Biologic, that doesn't sound good.
I think when you hear the term biologic, I want you to associate it with an option. And what I mean by that is when you look at biologics, all they're doing is they're inhibiting specific aspects of inflammation. And so, for example, in this case, we might use a biologic that inhibits an interleukin 4 receptor. But what that means for you is we can get down to the very nitty gritty of what's causing this inflammatory problem. And what a biologic does is it addresses this inflammatory problem by inhibiting one aspect of this inflammatory problem. So it just calms down the entire inflammation and it allows you to feel a little bit better. So you have less exacerbations over time and you might improve some of that lung function as well.
Hmm. How do I take it?
So the way that we prescribe biologics is an injection, a subcutaneous injection every 2 weeks. The reason it's an injection is because it's a systemic therapy. So this biologic or this monoclonal antibody will diffuse across your skin, your subcutaneous tissue, and get in your system. And then it will specifically bind to a receptor, calming down that inflammatory process.
Doctor, what kind of side effects does this biologic therapy have?
That's a good question. Whenever you take a systemic therapy like this, there's always a risk of having a rash. You can have an hypersensitivity to it. I haven't seen it in my clinical practice. I haven't seen anyone have a significant hypersensitivity where they end up in the ER or they end up in the hospital. I have seen people with rash, but there are things like that that I have to look out for. It's pretty well tolerated, and the adverse events aren't that dissimilar from anybody who was on placebo in the clinical trial. But these are things that we watch out for and will continue to watch out for it. So when you come into the office and get the injection, I'm going to let you hang around the office for about 15 to 30 minutes or so just to make certain. But we shouldn't have any problems. Again, clinically, I haven't seen one, but I think it's just to be cautious.
All right. Thank you.
I think for you, it's a great option because I think it allows you to feel a little bit better. And that's something I look forward to. I've had multiple patients that I placed on this biologic, and they do feel a little bit better and they have less exacerbations. And not only do we see this clinically, but we also see this in the medical literature, and that's important.
That's terrific. It sounds like I could actually play with my grandchildren a little more without getting short of breath, right?
I think that's the goal. Again, I have a mother, she's a grandmother, and that's the thing that I look forward to most. I look forward to her interaction with my children because I know it's important as we move forward in life. And I want you to do the same and feel good while you're doing it. So I'll see you in the office in a couple of weeks. We'll get started on the therapy and we'll go from there.
All right. I'll make an appointment. Thank you very much.
You're welcome. Take care.
Bye-bye.
So now let's look at some other emerging biologic options for COPD. Now, I will say that actually the company that makes mepolizumab just came out with a statement, a press release saying that their phase 3 matinee study, which is studying mepolizumab in patients with eosinophils greater than 300, that study was positive, meaning that it showed a reduction in moderate to severe exacerbations versus placebo with mepolizumab in patients treated for up to 104 weeks, so over 2 years. And so that data is not out. It has not been peer reviewed yet, but it does suggest that, hey, if this data really is positive after peer review, that maybe we even have another drug down the pipeline. So benralizumab, we actually already talked about this data that they did see. They did a responder analysis because they did not see any improvement with benralizumab versus placebo in all comers. But when they looked across patients with blood eosinophils greater than 300, with a history of exacerbations, and with exacerbations during the study, they did actually see that there was a specific responder group. So again, suggesting that maybe this anti-IL-5 receptor blocker or anti-IL-5 receptor drug also works in COPD. And so the study's there to look in this kind of responder population. So again, with higher blood eosinophils are ongoing, and hopefully we'll read out in the next year or two. Okay, so now we're actually going to go a little bit upstream to the alarmins. So the alarmins being IL-33 and TSLP. Actually, there's IL-25 as well, but that one's not studied as well. And so when we think about the alarmins, so they are best studied. So as you know, you get an injury to the airways, and it leads to release of these alarmins to kind of signal down the cascade to inflammatory mediators. And in general, we think of them, they're best studied in terms of type 2 biology. However, they are also thought to be somewhat context dependent. So potentially signaling to other pro-inflammatory mediators like type 1, so interferon, TNF-alpha, or type 3, so IL-17, and those things being kind of antiviral, antibacterial type responses that may also cause downstream pathology. And so it's a little bit we don't completely understand how those alarmins really function. A lot of those studies are done in preclinical models where what we're trying to understand now is, okay, well, how do you work in patients like a COPD patient who's got a smoking history that might be different than our asthma patients who's all has more type 2 biology. So these drugs are kind of being studied in a wide range of patients, and we're kind of gleaning some information based on those. So itepekimab is an anti-IL-33 drug. So it was studied really across all comers in a phase 2 study that was released a couple of years ago. And really what they found was when they studied all comers, they did not see an exacerbation reduction. But when they did one of their pre-specified post hoc analyses, what they found was that it was really the former smokers that they saw some benefit in. And they saw this kind of for exacerbation reduction and lung function improvement. And so their studies, again, they have phase 3 studies that are ongoing, but they're suggesting that their drug, their anti-IL-33 drug, really works best in former smokers. And they do suggest that current smoking is potentially diminishes IL-33 expression, both at the protein and the gene expression level, and that maybe that's part of the reason. But that's, again, some of this is ongoing. So tozorakimab is another drug, another anti-IL-33 drug, and they also just came out with a phase 2 study. So a smaller study where they looked at the drug in about 130 people, and kind of looking across the board. So it was really powered really to look at lung function, and they also looked at COPD complex. So they didn't actually look at exacerbations. They looked at this kind of exacerbation event monitoring, this complex score. And what they found was that again, it did not show benefit in all comers, so over everybody, but they did glean some insights from the study. First of all, they actually just, you only had to have a history of one exacerbation or more to be included in the study. And what they found was that the patients who had two or more, so the people who are exacerbation prone, who are the people that they'll be studying in their phase 3, seem to have more benefit. The patients with blood eosinophils greater than 150 seem to do better, and they actually didn't really see a difference in the current and former smokers. So again, it's interesting. Are the pharmacodynamics different here than with itepekimab, or is it really that we just need the phase 3 studies because these studies are too small to really be telling us the exact responder populations? Astegolimab, which is it's actually another drug that's targeting the IL-33 pathway, but this time it's targeting the receptor. So ST2, which is the receptor for IL-33, was studied again in a phase 2 trial. And actually here, what they suggest is that they seem to have better responses, both in exacerbations and in lung function, in the people who have low eosinophils, both low blood eosinophils and low sputum eosinophils. Now, again, small studies. We're looking at trends, and these were not significant. But again, they're kind of suggesting, hey, maybe our responder population has the lower eosinophil count. So maybe this drug is working more in a non-type 2 pathway. So interesting that we're seeing kind of these different responses across these phase 2 studies of targeting IL-33 and kind of using different molecules. And it's interesting thing about biologics is they're very complex and they can sometimes work. Their pharmacodynamics and how they work could be different. However, I think we need the phase 3 studies to actually know how they work. And then our final one is tezepelumab, which is targeting a different alarmin. So this one targets TSLP, and of course, this drug is already approved in asthma, whereas the IL-33 drugs are not. But they did the phase 2 course study, and this was presented at ATS, and this was done in 333 patients. And again, what we see here is that the overall patient population, there was no response. So meaning they looked over everybody with elevated eosinophils, and again, kind of a similar patient population of history of exacerbations. And really what they're seeing is that they don't see an improvement in exacerbations overall. However, when they look at, when they do their secondary analyses, they do seem to find a responder population. And so this one is a group where that their responder population they see is has blood eosinophils greater than 150. And they kind of saw that overall with their SGRQ and their pre-BD FEV1 as well, that really it's this is the responder population, is the patient population of greater than 150. So kind of interesting because we do think of TSLP, it's very well studied in type 2 inflammation. So is it really kind of a super type 2 inflammation, so you really only need blood eosinophils greater than 150? Or is that just a group that seems to be more pro-inflammatory, and so TSLP is actually working in multiple ways? Again, phase 2 studies, and so we're going to actually understand more about this as we come to further our phase 3 studies. So some of this is more just kind of a thought experiment of how are these drugs working? What is the biology that they are targeting? And hopefully we'll have some good biomarker studies in our phase 3 studies so that it can help us understand both the biology and how best to use these drugs to target the best patient population if, let's say, we can all hope that several of them get approved. Jamie, what are your thoughts on the biologics? Have you started using them in your patient? Have you started using dupilumab or anything else in your patients? And What about treating like asthma patients? And in this, we have our COPD patients and our asthma patients, and I use these drugs a lot in my asthma patients and find that they work well. And I'm interested to see how they, as I gain a kind of track record of using them in COPD patients. But what about you? What are you thinking about them?
I think the number one thing that biologics did for pulmonary is it almost forced an evolution. It forced us to think about inflammation as a disease state, right? It's forced us to think about how does the immune system's response to the environment lead to disease and how can we characterize this? And so, starting with asthma 10 years ago or whatever, when I started using biologics, that's when my thinking sort of changed and I just thought about inflammation. So I think that it's done wonders for the evolution of everyday medical thinking. But I think as a therapy specifically for my patients, like, yeah, I use them all the time. And any excuse I have to use them in a patient that I think would respond, I use them. And they have been most of the time efficacious. Nothing's perfect, but they've all been efficacious in their respective patient populations that they treat.
And what do you think? I think because we talk about in the asthma literature, we talk about things like remission, and we're not really going to get that in a COPD patient where we've got fixed defect already. And so, I guess, what are your kind of, expectations, or what to you suggests a good response in a COPD patient, and what would you be looking for? Because I think that's it's going to be a little bit different, right?
Yeah, so this is when I bring in my mother-in-law. My mother-in-law has severe COPD. She's 76 years old. She's got a significant amount of emphysema and she has chronic bronchitis. So she has both. She had demonstrated type 2 inflammation 5, 6 years ago. She was on, and because of the type 2 inflammation and her exacerbation history, she would exacerbate like 5 times a year, like all the time. And she'd be admitted to the hospital. She'd be in the hospital for 7 days, 8 days, 9 days, in the ICU for 2, 3 days, right? Once we put her on a type 2 inflammatory product, um, her exacerbation number didn't change. In other words, she still had, 3, 4 exacerbations a year. Maybe it went down one, but the amount of time she spent in the ICU and in the hospital completely changed. So instead of being in the hospital for 8, 9 days, she was in the hospital for 2. Instead of being in the ICU for 72 hours, she was in the ICU for 12. And so it significantly impacted her life. And when I think of inflammation, when I think of the immune system, that's how immunology works. Like the recruitment and the presence of inflammatory cells kind of gears up, gets to a point, affects you physically, and then we can use our therapies to calm down over time. But if my patient's on a therapy that keeps it somewhat calmer than previous, I do not expect them to have the same degree of inflammation in the future. And I think that that is very, very tough for us to measure as a society, as a medical society, because we look at lung function, we look at exacerbation number, like 1, 2, 3. We don't actually look at overall inflammation and how it impacts patients. And so for me, in regards to my mother-in-law, who is honestly kind of dying of COPD, um, it's affected her life in a very positive way because she gets to spend more time at home, right? Instead of in the hospital. That's how I look at it.
Yeah, no, I think it's a really good point. And you've got patients who maybe already have things that are never going to get better, or they may have, they've got comorbidities. This patient population has a really high comorbidity rate, right? So they may have other things that are kind of limiting how much they can respond, like potentially like your mother-in-law. Like she's not necessarily going to not go into the hospital, but you can significantly impact her life. And I think understand, talking to our patients and really communicating about that. And, are you, can you do more? Can you because I think a lot of patients limit themselves. They limit themselves when they're not doing well, and so then they don't tell us about symptoms. And so I think really kind of understanding those kind of broad levels, I think it's a really good point. So I like the way you think about it. And I'm hopeful actually that also gets that feeds downstream, that we get more of our primary care colleagues also thinking about inflammation, so that they are maybe measuring eosinophils and considering these drugs if, or referral to pulmonologists, to really get on top of patient care for these patients. There's a lot we can do for them. So, yeah, I think it's a
And you
great
know
way to
what's
think.
funny? I'll tell this other last story because I think it's important.
Yeah, please do.
She, she lives in Kansas City, and she was getting her carpet taken up. Like they were going to take up all the carpet and make the entire house a wood floor, which I thought was smart. But the carpet guy said to her, "Hey, you might want to leave and go stay in a hotel for a couple days because we're ripping up all this carpet that's been there for 50, 60 years in the house where they live." And she's like, "No, I'm staying in the house." And what happened? COPD exacerbation, ICU for a week. Right. And I was just like, if I got the carpet guy thinking about inflammation, right? Like, then that's, I think, like, this just shows a graduation of the thought process amongst human beings. And so if we
Yeah.
can get everybody to sort of think that way in terms of exposure and antigen, like, I think it can do some good for society. And I think with the institution of biologics in our medical society, it allows for that thinking to take place. So I applaud it. I appreciate it. And I thank God that we have them.
Yeah. Well, that was a good, I think, last story as a it's a nice you're right. It's like a nice thought that maybe this is starting to infiltrate kind of the public health knowledge as a whole. So I like that. Thanks. All right. So thank you so much for joining us tonight. We talked about a significant unmet need in COPD management, including the need for targeted therapies to address the underlying pathophysiology leading to disease progression, such as type 2 inflammation. Biomarkers continue to emerge. And may help us select patients who would most likely benefit from these therapies. I think that's happening already with eosinophils. Dupilumab is now approved for use in patients with inadequately controlled COPD and evidence of type 2 inflammation. And there are several others currently under studied. And so we're really hopeful that we have multiple choices for our COPD patients. So thank you so much for joining us tonight. And thank you, Dr. Rutland, for providing your insights to this discussion.
Thanks a lot, Stephanie, for having me. Really appreciate PeerView's involvement with this process. Much appreciated. And we look forward to seeing you all at our next meeting.
Yeah, great. So I hope everyone has found this activity to be useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/MKD860.